Today, we're diving deep into a fascinating medication called Aripiprazole. Now, this isn't your typical drug that just does one thing. It's not simply an antipsychotic or an antidepressant. Think of it more like a really sophisticated tool for the brain. What makes it so unique is that its effect completely changes depending on the dose. It's a dynamic stabilizer for the brain's dopamine system, and we're going to break down exactly what that means.
Okay, so here's our game plan. First, we're going to establish this core idea of aripiprazole as a stabilizer. Then we'll get into the weeds of its mechanism, something called partial agonism. From there, we'll look at how it affects different parts of the brain, see how that translates into real-world clinical effects, and then finally, we'll put it all together in a final model covering the risks and limitations too. All right, let's start with the central thesis. To really get a handle on aripiprazole, you have to shift your thinking. It's not just turning dopamine up or down, it's modulating it. It's a stabilizer.
And this definition is really the key to everything. You see, most traditional medications are pretty straightforward. They either block dopamine receptors, acting as an antagonist, or they stimulate them, acting as a full agonist. Aripiprazole, well, it does both. Its job is to find a happy medium. It can turn the volume up in parts of the brain where dopamine is too low, and it can turn it down where there's way too much. This amazing adaptability is exactly why it's used for so many different conditions.
So, how in the world does one molecule do that? Well, to understand that, we have to zoom way into the microscopic level. The whole principle boils down to a concept called partial agonism. You know, a partial agonist is kind of like a dimmer switch for a light bulb. A full agonist, on the other hand, is just a simple on-off switch. Aripiprazole binds to the dopamine D2 receptor, but it only gives it a little bit of a push, just a fraction of the stimulation that the brain's own dopamine would. And this in-between level of activity is what makes it such a good modulator. It basically sets a ceiling so the receptor can't get overstimulated, but it also provides a floor so you don't have a total lack of stimulation either.
And this right here, this quote just perfectly captures the drug's two-faced nature. Think about it. In a brain where there's not much natural dopamine floating around, aripiprazole's gentle stimulation actually causes a net increase in the signal, so it acts like an agonist. But in a brain that's flooded with dopamine, it jumps onto those receptors and provides a weaker signal than the brain's own dopamine would have, so it ends up competing with dopamine and blocking its effect, essentially acting as an antagonist.
This table just lays it all out so clearly. You can see how dose is everything. At a low dose, say 2 to 5 milligrams, aripiprazole takes up about half of the D2 receptors. Since a lot of receptors are still free, its main effect is to add a little bit of stimulation. So its dopamine boosting or agonist effect is what you really see. As you bump up the dose, more receptors get occupied, and its effect becomes this weird mix of boosting in some places and blocking in others. Then, at a high dose, it's occupying almost all the receptors, and its main job becomes blocking dopamine's effects. It becomes, for all intents and purposes, an antagonist.
And here's the crucial point, which has actually been confirmed with PET brain scans. At the highest doses, around 30 milligrams, aripiprazole basically saturates the D2 receptor system. When over 90% of your receptors are taken up by this partial agonist, there's just no room left for your brain's own dopamine to do its thing. So in a condition like psychosis, where the problem is too much dopamine, this high level of occupancy just quiets that whole overactive system down, giving you a really strong anti-dopamine effect.
Okay, so now that we've covered the how, let's talk about the where. Because the brain isn't just one big soup of chemicals, right? Different pathways have different jobs and different amounts of dopamine. So aripiprazole's effect isn't just about the dose, it's also about the specific location in the brain.
So let's start with the mesocortical pathway. This pathway goes to your prefrontal cortex, the part of the brain that's all about focus, planning, and motivation. In conditions like depression, this area is often low on dopamine. So here, at low doses, aripiprazole acts as an agonist and gives that dopamine signaling a nice boost. That effect gets a little extra help from its action at serotonin receptors too. But at high doses, because so many receptors are occupied, that boosting effect kind of gets canceled out, and the result is more neutral.
Now let's compare that to the mesolimbic pathway, the brain's reward system, which is often overactive in psychosis. Here the story is completely flipped. At low doses, not much happens, but at high doses, aripiprazole occupies most of the receptors, and it outcompetes all that excess dopamine. Its own lower-level stimulation acts like a cap, bringing the overall activity down. And that is its core antipsychotic action.
This amazing regional specificity also explains why its side effect profile is often better than older drugs.
For example, in the nigrostriatal pathway, which controls movement, older antipsychotics would just block everything, leading to serious motor side effects. But aripiprazole's partial agonism gives just enough of a signal to avoid that. Same story in the tuberoinfundibular pathway, which controls the hormone prolactin. Full blockade makes prolactin levels spike, but aripiprazole's gentle touch keeps things in balance, making it prolactin-sparing.
Okay, so this is all some pretty cool neurochemistry, but what does it actually mean for patients? Well, we can now draw a direct line from the dose to the brain region to the therapeutic outcome.
You can see this beautiful progression right here. At low doses, you're primarily getting that pro-dopamine effect in the prefrontal cortex, which is perfect for tackling symptoms of depression and low energy. At moderate doses, the drug is creating this balance, boosting dopamine where it's low and tamping it down where it's high, which provides mood stabilization. And then at high doses, that anti-dopamine effect in the reward pathway takes over, giving you a powerful antipsychotic effect for something like schizophrenia or mania. And this is exactly how a clinician can put all this knowledge to work. If you're targeting depression, you use a low dose to boost another antidepressant. For anxiety, that same low dose can have a calming effect through its action on serotonin. If you're dealing with milder psychosis, an intermediate dose might be enough. But for severe schizophrenia or mania, you need to go to those high doses to really shut down that overactive mesolimbic system.
All right, let's bring it all home. We're going to synthesize all this information into one complete model. But we also have to be honest about the potential risks and the limits of what we currently understand.
What's really interesting is that even the side effects are a direct result of this mechanism. Akathisia, which is this awful feeling of inner restlessness, often shows up at moderate doses, probably because the system is just fluctuating wildly between being turned on and turned off. Insomnia or feeling too activated can happen at lower doses because of that dopamine boost in the prefrontal cortex. And while the risk is pretty low, you can still get some movement side effects at the highest doses because, well, even partial agonism at over 90% occupancy can still get in the way of normal movement control.
Now, we have to be critical of this model. We know for a fact from PET scans that the dose determines how many receptors get occupied. That's solid evidence. But the specific effects in different brain regions and how that translates to symptoms, that's inferred. It's a really powerful and useful model, but it's still a model. And the biggest challenge in the real world is that this mechanism isn't linear, which can make it tricky to predict how any one person is going to respond.
So, to wrap it all up in a nutshell, aripiprazole is a dose-dependent dopamine stabilizer. At a low dose, it's pro-dopamine in the prefrontal cortex, which makes it act like an antidepressant. At a high dose, it's anti-dopamine in the mesolimbic pathway, which makes it an antipsychotic. This ability to go both ways, all depending on dose and brain region, is its signature move. And that leaves us with a final, pretty profound question. Aripiprazole really represents a move away from blunt instruments and toward these highly specific, context-aware modulators. If one molecule can be fine-tuned to produce completely opposite effects, it really makes you wonder. It suggests a future where our treatments could become way more nuanced, targeted, and truly personalized to an individual's unique brain chemistry.